Hello, everyone. I'm Andrea Jia, and I'm from the Clinical Surgical Oncology Editorial Office and GMED, Jiang Medical Research and Education Group. GMED is educational arm of Jiang Health, and for CSO, it is a journal that seeks innovative research and advancements in surgical oncology. Today's webinar is the fourth one, co-hosted by ESSO and GMED. The three ones held in 2024 received a great deal of attention and produced much academically valuable content. I would like to thank all the experts who supported these webinars, as well as Karen and Anna from ESSO office. Today, I'm also very thrilled that ahead of the 19th Shanghai International Breast Cancer Conference, we have invited very important breast cancer surgical scholars from Europe and China to discuss the topic of molecular testing in the diagnosis and treatment of breast cancer. I believe this will also bring new perspectives to many doctors watching the conference online. Thank you all once again for being here. Next, I would like to invite Dr. Carmela to continue introducing and moderating the following session. Dr. Carmela is a surgeon and clinical researcher based in Brussels, Belgium. Welcome. Thank you.
Hello. Thank you, April, for introducing me. On behalf of my of ESSO and also our colleagues from JMED and CSO, I'm very, very happy to welcome everyone from all over the world to this wonderful ESSO JMED CSO webinar series that we are starting. I have a wonderful co-host and co-moderator today who's also an expert in breast cancer surgery and research, Marius Tasoulis. And today we will be tackling optimizing breast cancer surgery and integrating molecular insights into this surgical decision making with an expert panel that we have. So we have Professor Michael Gnant, Professor Jiang, and Professor Shelley Potter. I will be introducing them later, but maybe we can provide a brief introduction about ESSO, which is the other half of this collaboration. ESSO is the European Society of Surgical Oncology, and we are advancing science and practice of surgical oncology globally for the benefit of those with a lived experience of cancer. And we are doing this through the help of more than 4,000 members around the world, through the conduct of our annual Congress, certification programs, educational grants, and in-person courses and webinars. Next slide, please. So this is the portfolio or summary of what ESSO has been doing in the last, probably last decade already. Next slide, please. So we are encouraging everyone to be part of ESSO. You just need to click or scan this QR code, and there will be a lot of benefits, especially for young surgeons who are wanting to be experts in cancer surgery. Next slide, please. We are also inviting you to the upcoming ESSO-44, which will be in Sweden and Gothenburg. And I'm very happy to see that our past ESSO president is here also from Sweden. Ricardo Audicio is also here. So happy that he is participating. And you can see here the important timelines for the Congress. We are inviting you to go to the website of ESSO-44, submit your abstracts for these different disease groups. And also we are welcoming surgical trial proposals. Next slide, please. So hoping to see you all from 15 to 17 of October 2025 in Sweden, Gothenburg.
I would like to welcome everyone in this webinar. As Carmela said, this is a webinar looking into how we can optimize surgery, looking into molecular subtyping and types of breast cancer. And we have an excellent panel of speakers today, Professor Gnant, Professor Potter, and Professor Jiang, that will give us very insightful talks about how we can optimize the care of our patients in the modern era of multidisciplinary management. Again, I would like to welcome you all. Hope that you will find the webinar particularly useful. We will have some discussions after each presentation, so please feel free to ask any questions that we can also discuss during this time. And then hopefully we can move on to the next part, which is just a brief introduction from Professor Kovacs, and then get to the talks. Welcome, everyone.
Thank you very much, Marius, and thank you very much for, first of all, the faculty for ASAC. This is a collaboration between ESSO-ASAC and Clinical Surgical Oncology, which is a new cancer surgery journal established by and hosted by Jiang International Hospital and JMed, published by Elsevier. It is an internationally peer-reviewed open access journal, which has been recently indexed and is focusing, as you can imagine, on surgical oncology in what regards surgical oncology research, clinical practice, and management. And the current webinar is also an example of collaboration between European societies and also colleagues from China. We try to expose and we try to present the excellent work which is done both in Asian countries, in China, and in Europe, and to try to find a collaborative approach between different continents. The journal itself has 4 regular issues per year, and we have 2 special issues planned for 2025, AI in surgery and surgical oncology, and surgery for pancreatic disease. Once again, thank you very much for you all speakers, and we have, I think, quite a good number of participants. The webinar is transmitted on different Chinese social media channels and platforms, and also on Zoom in Europe. Thank you, and have a nice time.
So I guess we can start with the expert panelists who will deliver us the talks for today. We have Professor Michael Gnant, who is a full professor in the Medical University of Vienna, and he is also the president of the Austrian Breast and Colorectal Cancer Study Group. He has led several clinical trials that have contributed significantly to the practice of breast cancer surgery. And today we welcome him for his wonderful talk on how we can eliminate mastectomy. Professor Gnant.
Yeah, thank you very much. I'll try to share my slides. Can you see my screen? Does it work?
Yes.
Very good. So thanks a lot, Carmen, and for inviting me to this. It's a great honor. Here are my disclosures, and as you can see in the part below, I have a lot to do with my Chinese friends. I work with some Chinese institutions, and my friends have even honored me by giving me a Chinese name, which I will not pronounce because it might sound ridiculous, but you can read it and you know what it means. And we have a wonderful collaboration, not only in the preparation of the Shanghai meeting, as Andre already said. We now have more than 100 Chinese physicians registered to come to Vienna 2 weeks from now, and we hope that after today, maybe some more may consider doing that. Looking at Vienna, this is not where I live, but this is where our plastic surgeons live. So I have a more modest house, as you can imagine. Austria is a tiny country for Chinese relations. It's almost ridiculously small with just 9 million people, but we have wonderful breast cancer patients, of whom 30,000 actually contributed to randomized clinical trials in breast cancer in the last 4 decades. And this makes us a little bit more important than by size, probably in the breast cancer world. And it's also the reason why the Shanghai Breast Cancer Conference that defines the standard of care every other year has moved to Vienna now already 10 years ago. We called it the largest tumor board in the world. 80 experts from all over the world, including China. This time we have 4 Chinese panelists, and we are very proud of that. Convene and define what should be done next week with all the innovation, and that's always also resulting into a prestigious manuscript defining these opinion-based guidelines, however. So, to the subject, I will set the stage per invitation of our chairpersons for the de-escalation of breast surgery, and then the wonderful Shelley Potter will address the moving field of axillary surgery. I'm going to talk a little bit about avoidable mastectomies, and I apologize to my wonderful colleagues who have done so much in great oncoplasty and reconstruction and all of that, but I have to tell you that at some point, we are not going to need this any longer because we will have eliminated mastectomy. And as I will show you, and I'm not suggesting you do all of that, what I'm suggesting, I'm just trying to tell you where the way eventually can go to define breast conservation as a standard of care, technical but also strategic aspects of breast conservation. And as breast surgeons, we have to admit, and I'm very grateful to MJ Cardozo, another wonderful breast surgeon in Europe. She gave me that slide, and I like it very much because we have a tendency to jump to new fashion. And the new fashion now is do less surgery and do not surgery at all at some point. And I think we need to be a little bit cautious with some of that. We need to define everything with clinical trials, and that's what we try to do, despite the fact that it's not so easy to conduct clinical trials in surgical aspects because the funding is an issue. However, particularly our Chinese friends, I mean, in Fudan, you guys are going to do 10 or 11 or 12,000 breast surgeries just this year, so you really have even better opportunities for clinical research in breast surgery than we have. The mega trend, obviously, is going away from mastectomy to breast conservation. And we achieve this by a number of, I would call that sub-issues. Obviously, the strategic approach. There is surgical technique approach. And I'm just a quick word of, some people say, well, maybe we may not need breast surgery at some point. And I will answer this with another great breast surgeon, Monica Moro, the grand dame of breast surgery. She said, yes, we might consider this in individual cases, but it's not a top priority of our patients. Breast surgery has become a rather simple, non-invasive procedure. If it's not simple for us, but it's relatively simple and non-invasive for patients. Meanwhile, it can be done as an outpatient procedure in many aspects. And not having any breast surgery any longer is really not the top priority of patients. Now, what do we need to, in perspective, eventually eliminate mastectomy? I think most important is the mindset. We need to realize that the breast conservation is the standard of care. Because do not harm means for the surgical oncologist, and we are trying to preserve, I don't know, in rectal cancer, the sphincter, and we preserve parts of the stomach in gastric cancer, and we preserve, we do pancreatic partial resections and all of that. And, even more important, because visible and important for the social, sexual, and psychological identity of patients is preserving the breast. And so I think we just need to accept every mastectomy per principle is kind of a failure. And when we are successful, we need to eliminate that. And just to put this in perspective, of course, this is easier when we manage to detect breast cancer early. And I'm a strong advocate for surgeons not only being in the theater all day, but also engaging in politics, in the healthcare system, because it makes our job easier if we detect the breast cancer early. In many environments, and I know that's not true in all parts of China, there is population-based screening. We cannot prevent breast cancer from happening, but we can prevent anyone from dying from the disease if we just detected every breast cancer early enough. And I'm showing you an example here. You see, even without being a radiologist, that there is something in the left breast on the right side here in this image. And it's, as a matter of fact, I will help you with magnification. It's a 1 millimeter breast cancer detected by screening. And there was even an MRI done, which you can consider, unnecessary expense. And you again see the breast cancer here, and that's the specimen radiography. And when you look at how big that histology specimen, it's barely 1.5 centimeters. So obviously, we, in such a case, have a relatively easy job to achieve both goals. Number one, cure the patient. At 1 millimeter, cure is almost 100%. Number two, do not mutilate the patient, because everybody, you don't have to be an experienced breast surgeon to do this without aesthetic compromise. Probably in the future, we might have other technologies in addition to screening imaging programs. I'm very optimistic that circulating tumor DNA, eventually, it's not ready for prime time, but maybe in 5 years or in 10 years, we can actually early detect breast cancer from taking a blood sample, which obviously would make it much easier for healthcare system to do that. And eventually we have to work together in all disciplines. And why is this important also for the breast surgeon? It's because if the tumor is too large or was not detected early enough, then we need to shrink this tumor using neoadjuvant systemic therapy. And I think what we understand, and here is where the molecular subtypes come in place, because that doesn't work equally well in triple negative as compared to hormone receptor positive breast cancer, but moving the systemic treatment, the drug treatment, from where its mainstay used to be, which is the treatment of metastases or adjuvant treatment, to before surgery, I think is a process in the interest of the surgeon. And in the beginning, when I started doing this personally in my practice, it's almost 30 years ago, people were yelling at me. They were not referring patients anymore. They said, we send you the patient to cut the tumor out, not to do some drug treatment. However, once the breast surgeon understands that his or her job is much easier when we shrink the tumor, then, they become real fans. And I'm showing you an extreme case here. And again, I'm not suggesting that this would be a standard, but where we can go. This is a 12 centimeter tumor in a 36-year-old patient, as you can see on the MRI. The patient actually was a lawyer, which is usually a particular challenge for all the physicians. And you would not consider breast conservation in such a case. However, she was lucky, and this was a HER2 overexpressing breast cancer. And at such size, there is clearly neoadjuvant systemic immunotherapy, chemoimmunotherapy, the standard of care. And that's what we did. And eventually it led to substantial shrinkage, actually shrinkage towards nil, just some remnants in there. And after 6 months, we were able to perform breast conserving surgery. And there was, as a matter of fact, a complete pathological remission in the breast. And there were just some remaining tumor cells in sentinel lymph node. And this is the aesthetic result after 6 months. I'm not usually showing patient images because I rather show curves and tables, but I think this is an impressive example. It's now 5 years out, and this patient, starting as a young lady after pregnancy with a 12 centimeter tumor, still has her breast, and that's about a couple of months ago, and she's obviously very happy with that. So here is where the subtypes come into place. Current guidelines suggest that, every tumor larger than 2 centimeters, if HER2 overexpressing or triple negative, should be treated neoadjuvantly. And I'm just telling you, in my institution, we are going far below that. So we will treat every of these tumors from 5 millimeter or larger. Again, no standard, my personal opinion, because these patients will have postoperative systemic treatment anyway. And if they have to have that, I would rather give the very same treatment before surgery in order to make the surgeon's jobs easier. And we can clearly discuss about 6 or 7 millimeters, but for 15 millimeters, that's definitely there. In triple negative, we now have checkpoint inhibitors that help us increasing the PCR rates by approximately 10 to 15%, in addition on top of what neoadjuvant traditional chemotherapy can do. And, PCR rates of 50, 60, 65%, that is rather encouraging. And I think it should be done for all tumors at least larger than 2 centimeters. Next important piece in the puzzle is obviously surgical techniques. We have so many prominent breast surgeons around that. I'm not going to dwell on this, but you know all the techniques that we have developed. Surgery is a wonderfully patient-directed but highly innovative field, and it's sometimes even an art, and I think many of us use all of these techniques. And I'm just saying we can pushing this, because when you look at the list of where is a contraindication for breast conservation, people will keep saying, well, extensive DCIS. Again, I'm showing you a case, huge DCIS. And still, because DCIS usually grows segmentally, when you have a good collaboration with your radiologist and you do all of that, in this case, it was even involving the nipple with Paget's disease. And what you can see is the specimen radiography, again, over 10 centimeters, but a complete excision with a somewhat interesting approach, I would say, including the resection of the nipple, as you can see, but eventually a very reasonable aesthetic reshaping of the breast cancer. DCIS cured. No further, terrible treatment necessary for this patient, and breast conserved for this lady. And she might not be able to go topless, but it's actually a very acceptable result. And this is where it can go. And again, I'm not suggesting this should be the case everywhere, but that's my institutional breast conservation rate over the last 5 years. And as you see, we are now closing into about 95%. And that's feasible with the aggressive use of neoadjuvant systemic treatment based on our early detection system, which we have, and I realize it's not present in every part of the world. Eliminating the contraindications for breast conservation, I think, must be an important goal of breast surgeons. And the last Shanghai meeting actually defined some of that in fierce discussion among many prominent breast surgeons from many countries in the world. And there's 3 subjects to this. Number 1 is, yes, oncoplastic breast conserving surgery was approved even in extreme cases. Second, multicentricity, that in all the textbooks still is a contraindication for breast cancer, was under certain conditions eliminated from that list. And local recurrence actually has already been eliminated before. And I'm showing you the voting results. Oncoplastic high volume resection, so we call that extreme oncoplasty, is an alternative to mastectomy. And as you can see, the panelists with large majority, even in 23, voted, and I'm very confident that this time it will even be a larger majority. Second, 2 breast cancers in 2 neighboring quadrants. Can we do double tumorectomy? A no-go until 10 years ago. 2 years ago, the Shanghai panel for the first time had a majority for yes, double tumorectomy and radiotherapy is quite acceptable. This. And again, I'm going to show you an example here. So this is a 57-year-old lady with 3 biopsy-proven luminal tumors in her right breast. As you can see in the MRI, it's 2 neighboring quadrants, but 3 individual tumors. And obviously that needs a lot of planning. You need excellent interaction with your radiologist. The pathologist is also an important person in here. You need extensive localization procedures. We are using wires, but you can use magnetic beads or many other things. And eventually that's how it looks for the surgeon when we start. And here you see the specimen radiography with the 2 clips that were placed to 2 of the 3 tumors. And that's the aesthetic outcome the day after surgery. So 3 tumors, 1 breast, multicentricity, breast conservation is possible and was approved by the Shanghai panel. And the third topic is, when we treat local recurrence, it's not an automatic mastectomy. We can do another breast conservation, provided that we can achieve, the radical principles of oncologic surgery. And what I also have to say, and I apologize for being a little bit ideologic in that, we have to stop doing unnecessary mastectomies. We still see mastectomies based on fear. Can you remove the other breast because I'm afraid the cancer might show up there? Nobody does a colectomy just because colorectal cancer is a prevalent malignancy. Nobody does an orchiectomy because of fear for testicular cancer. So why are we doing this? And I'm not talking, obviously, about the germline mutation where we have risk-reducing surgery. That's obviously a very good thing. But we often see mastectomies where they really are not necessary. Look at the clinical trials. PCR rate 60%. Why would we do a mastectomy in a complete pathological remission if we are just in a position to know that? And it's very interesting to see that actually the rate of mastectomy in institutions, but also regionally, depends on the surgeons and on social issues. Female surgeons are doing less mastectomies. Poorer people have more mastectomies. Rural areas have higher mastectomy rates. So higher socioeconomic stage increases your chance for breast conservation. Think about it. That's not a medical factual reason. It's a society, social, and psychological reason. And patients' wish, dear surgical colleagues, is not an excuse, because we are the most important impact makers on that patient decision. And there is even data to that. It's not the spouse, it's not the kids, it's not the medon, it's the surgeon and his or her information that assists the most and most impactful on our patient's decision about the surgery. So to summarize, breast conservation is the standard of care. Yes, if we have early detection, this is why I engage myself in promoting this. We need to use neoadjuvant systemic treatment whenever possible. Yes, we need to train our younger colleagues to have all these wonderful oncoplastic techniques at a high level delivered by specialists, probably not by general surgeons in the future. We have to eliminate some of the remaining contraindications for breast conservation, and we have to stop unnecessary mastectomy. So I condense this to the take-home message. Never do a primary mastectomy. Never do an unnecessary mastectomy. And I apologize for being provocative a little bit. I hope to be able to keep that discussion going with many of you in 2 weeks' time in Vienna. And with that, I thank you very much for your attention. Thank you.
Thank you very much, Michael. That was an excellent talk. Maybe I would like to ask my co-moderator, Marius, if you have some questions, or if the other panelists also have some questions, at least 1 or 2 questions for Michael.
Yeah, I would like to thank Michael for the great presentation. I think it was very comprehensive and just highlights why it is important to work as a multidisciplinary team to reduce mastectomies as much as we can. One question from me, in a scenario that I do find challenging, let's say women who have a woman who has a large cancer in the breast associated with microcalcifications, especially HER2-positive disease, which is quite common. We do treat with neoadjuvant chemotherapy, then not always, but quite often the microcalcifications remain. And then quite often people feel uncomfortable leaving microcalcifications behind, meaning the footprint of the potential footprint of the disease is still quite extensive. And then we end up doing mastectomies only to find out that there is a complete pathologic response. How would you approach this scenario where you have an excellent response to the solid component of the tumor, but we still have residual microcalcifications?
Marius, this is an excellent question. I can just tell you what I did. About 10 years ago, I stopped hunting for microcalcifications because I want to treat the cancer and not the microcalcifications. We did this in a cautious way. We did multiple biopsies, sometimes in addition to resecting the original core of the tumor. And, we became more and more confident. We are not hunting for MRI lesions, because we know they are always, over-interpreting, and we are not hunting for residual microcalcifications in a setting, as you said, of excellent response. So if I have a minor response, shrinkage from 4 to 3 centimeters, I would probably not dare to leave them behind. But if there is an excellent response, then I'm not worried that some microcalcifications remain. After all, it's, you're all too young for that, but a great surgeon by the name of Holland 35 years ago proved that we are always leaving some individual cancer cells behind, which is why we do radiotherapy after breast conservation. I'm not too much worried, but that was a learning of the whole team. So we started this 10 years ago. Nowadays, I will, with great confidence, in a situation as you tell me about of excellent response, I will leave some radiological remnants behind, and I don't worry about this. And our local relapse rate in these 10 years at least confirms that that's a good thing to do.
Thank you for that.
I would like just to emphasize what you said. In our practice, we're also doing vacuum biopsies to assess the residual microcalcifications, and then if we do not find any residual disease, we de-escalate surgery, and it is safe. We have seen our local recurrence rate to be similar compared to what we would expect. So just as a message for everyone attending the webinar, residual microcalcification post-neoadjuvant chemotherapy is not an indication to do mastectomy. So please work with your multidisciplinary team and try to individualize the surgery that you offer for your patients, because this way we can avoid unnecessary mastectomies, especially in the setting when we can expect an excellent response to neoadjuvant systemic therapy like HER2-positive disease.
Thank you for that, Marius. It's an excellent, I think, summary of the first part of our discussion. We will probably reserve additional questions later, but maybe we will proceed with another potentially provocative discussion about reducing the extent of axillary surgery that will be provided to us by Professor Shelley Potter, who is an associate professor at the Oncoplastic Breast Surgery and from the University of Bristol. She has also led a lot of collaborative projects and research activities that are related to helping patients to have an informed decision about the best kind of surgical strategies for them. So maybe we can now welcome Professor Shelley Potter.
Lovely, thank you very much. I will try and share my screen as well. Can you see that?
Yeah, we need to see the slideshow. We are seeing the presenter's view.
Sorry, seeing my emails.
No.
No, we see the presenter's mode, Shelley.
Yeah.
You need to have the full screen stuff.
Trying to right, let's try again. Let's stop showing that. So share this. So I'm going to share this and then share this. Lovely. Can you see that now?
Yes, perfect.
Lovely. Thank you very much for this invitation. I am going to speak about the uncontroversial issue of axillary surgery. So axillary surgery has been one of the most controversial topics in breast cancer surgery for a very long time. And when we're thinking about safely de-escalating surgery, what we really need to think about is why we're doing axillary surgery in the first place. Ideally, we're doing this to improve outcomes for our patients in terms of reducing the risk of the breast cancer returning or improving survival. But we've known for over 30 years from the seminal work of Bernard Fisher in the BO4 trial that not all women benefit from axillary surgery, and particularly those who have a low burden of disease with clinically node-negative patients have no benefit in terms of distant recurrence or overall survival with extensive axillary surgery. And we also know from more recent data from the early breast cancer trialists' meta-analysis of axillary treatment that whether patients are node negative or node positive, more extensive axillary surgery doesn't impact local regional recurrence, distant recurrence, breast cancer mortality, or death. So, axillary clearance has questionable oncological benefits, but what we know it does cause is significant morbidity for our patients. And 30% of patients having an axillary clearance experience life-changing, lifelong complications such as lymphedema, which profoundly impact their quality of life. And although for patients with a heavy nodal burden, we are achieving local regional control, for the majority of our patients with early breast cancer, axillary surgery is for staging. And that's a really important concept to understand if you're thinking about de-escalation. So I'm going to divide my talk into de-escalation in the primary surgery setting and in the neoadjuvant systemic treatment setting. So first of all, primary surgery. So as we all know, sentinel node biopsy is the standard of care for patients with clinically node-negative patients based on the NSABP B32 study, which randomized 5,611 women to sentinel node biopsy with axillary node clearance or sentinel node biopsy only if their sentinel node was clear. And at 8 years, there was no difference in overall or disease-free survival. And this led to a change in practice, de-escalating axillary node clearance to sentinel node biopsy in this population. But what do we do if we have a positive sentinel node? Do we still need to clear? And I think there's significant evidence now that we don't need to do further axillary surgery in this group. In terms of micromets, there's the IBCSG 2301 study, which looked at patients with T1 or T tumours having breast-conserving surgery or mastectomy who had micromets, so less than 2 millimeters of disease in their sentinel node biopsy. And they randomized over 900 patients to axillary dissection or clearance or no further axillary surgery. And there was no difference in disease-free survival or overall survival at almost 10 years of follow-up. So further axillary surgery is not needed for patients with sentinel node micromets. What about macromets? So deposits of greater than 2 centimeters. And the seminal trial was the AZACOG-Z, which was looking at patients with T1 or T tumours that were clinically node negative, having breast-conserving surgery and radiotherapy, who had 1 to 2 positive nodes. And 856 patients were randomised to axillary clearance or no axillary clearance if they had a positive sentinel node biopsy. And as you can see, there was no difference in disease-free or overall survival at 10 years, suggesting that omission of further axillary surgery is safe in patients with a positive sentinel node biopsy. However, Z11 has been heavily criticised. It was an entirely innovative trial and practice changing, but there were still some concerns. It was slow to accrue and achieved less than 50% of its target. The event rate was lower than expected, so it was underpowered.
Yeah, I think for you, no.
There was no radiotherapy quality assurance, so we don't, although patients may have had their axillary surgery, axillary surgery de-escalated, they may have had their radiotherapy escalated, so they would still have had more axillary treatment. There was poor treatment allocation and a high loss to follow-up. So this led to multiple other confirmatory Z11 trials going on to try and establish whether further axillary treatment was needed in the patients with a positive sentinel node. And actually, of note, 2 of these trials, the UK POSNOC study and the Boog study from the Netherlands, were looking at further axillary treatment, either with axillary clearance or radiotherapy versus no further axillary treatment. And this is on the basis of the Amaros study, which was looking at whether we should be doing axillary dissection or axillary radiotherapy for patients with a positive sentinel lymph node biopsy. And this study randomized 1,400 patients, clinically node negative, with a positive sentinel node biopsy to either surgery or axillary radiotherapy. And as seen with the previous studies, there was no difference. Radiotherapy was non-inferior to surgery in terms of overall survival and disease-free survival. What was dramatic, however, was that patients having axillary radiotherapy have significantly less lymphedema following surgery than those having following their radiotherapy treatment than those having surgery. So if you are going to treat patients with positive sentinel nodes, then axillary radiotherapy is a preferable treatment to surgery. And we have changed our practice and offer radiotherapy in this group. And this is another one of the Z11 confirmatory trials. This is CENIMAC, led by Jiang de Boniface, which randomized 2,700 patients with T1 or T tumours with 1 to 2 positive sentinel node macromets. And again, this has shown no difference in oncological outcomes between patients having sentinel node biopsy and those having completion axillary dissection. But almost 90% of patients in the sentinel node biopsy arm alone didn't have further axillary surgery, but they did receive nodal radiotherapy. So they were having additional axillary treatment. So I think in some ways, whether these patients need any further axillary treatment is probably still slightly up for debate. And also, all of these trials have looked at patients who are clinically node negative. And what happens if, like in the UK, you stage your patient's axillae preoperatively with ultrasound and biopsy any equivocal nodes? Practice is incredibly variable worldwide, but in the UK, our national guidelines recommend that if you have biopsy-proven nodal disease, you should offer patients an axillary lymph node clearance. This isn't the case in North America, where the National Comprehensive Cancer Network guidelines have been modified based on the Z11 criteria, where they recommend if a patient has 1 to 2 suspicious nodes or biopsy-proven nodes on ultrasound, and they're having breast-conserving surgery and whole breast radiotherapy, they could have a sentinel node biopsy. But there still exists some uncertainty about performing sentinel node biopsy in patients with biopsy-proven node-positive disease. This is because patients with ultrasound-detected node-positive disease have higher burdens of disease than those with clinically node-negative disease. There are concerns about false negative with sentinel node biopsy and potential understaging and leaving involved lymph nodes behind. So in the UK, at least, there is caution with performing sentinel node biopsy in this population. So how could we possibly safely de-escalate axillary surgery in patients with node-positive breast cancer? Well, there are currently 2 ongoing trials. There's the TAXUS trial led by Walter Weber from Switzerland, which is comparing targeted axillary surgery, which is removal of palpably abnormal nodes in combination with a sentinel node biopsy with radiotherapy, with axillary dissection, in patients with radiologically or clinically node-positive disease. The primary outcome is disease-free survival, and the sample size is 1,500. And in the UK, we are just setting up a tadpole study, which is looking at targeted axillary dissection without radiotherapy versus standard axillary clearance in patients with low-volume nodal disease, so just 1 to 2 positive nodes. And we're looking at lymphedema at 12 months and local regional recurrence at 12 years. So this is very much a watch this space. And are there actually a group of patients in whom we can safely omit axillary staging completely? Well, this is an area of great interest. And in the last 2 years, there have been 2 large-scale randomized trials, the SAM trial and the ENSEMA trial, looking at omission of sentinel node biopsy published. And there are 3 further studies, Nautilus, the BOOG, and Venus studies are ongoing. This table summarizes the ENSEMA and the SAN study. So the SAN trial was looking exclusively at small cancers, so T1 up to 2 centimeters, ENSEMA slightly larger, both looking at disease-free survival. And the most notable difference is that while both studies included radiotherapy, only the ENSEMA trial had quality assurance. They mandated whole breast radiotherapy, and they prohibited high tangents and regional nodal radiation unless patients had T2. So we can be very confident in the ENSEMA trial that we weren't replacing axillary staging with axillary treatment with radiotherapy, which is important. And unsurprisingly, if you look at the results, disease-free survival, and in both studies, there is no difference irrespective of whether patients had a sentinel node or omission of a sentinel node biopsy. So this is very much food for thought. So in who can we safely avoid axillary staging? Well, in North America, they've instigated the Choosing Wisely program and suggested that patients over 70 years who are ER positive and clinically node negative can avoid surgery. But based on the evidence from the high quality randomized studies that we've had, we could potentially change this to patients who are less than 50, who have T1 disease up to 2 centimeters and have luminal breast cancer, so ER positive, HER2 negative with grade 1 or 2. And these patients could safely avoid a sentinel node biopsy, which, although is a very safe and quick procedure, does have some morbidity. So what about de-escalation of axillary surgery in the neoadjuvant setting? And this is really where discussion of molecular subtypes comes into play, because if someone is node positive diagnosis, we know from the NSABP B18 and B27 studies that chemotherapy can downstage the axilla, and in these trials, more than 80% had a nodal response, and approximately 40% had a complete nodal response. And in the modern age, with modern treatments, particularly with triple negative and HER2 positive subtypes, the PCR rate can be higher, and we can use neoadjuvant systemic therapy as a tool to downstage the axilla to convert from node positive to node negative. And this will also allow us to de-escalate the extent of axillary surgery. But how do we safely de-escalate? There have been a number of studies looking at the performance of sentinel lymph node biopsy in patients who convert from clinically node negative to clinically node positive following neoadjuvant systemic therapy. And what these 5 studies have shown was that sentinel node biopsy alone had unacceptable false negative rates of between 10 and 15%. This led to the development of the technique of targeted axillary dissection, which combines a sentinel node biopsy with removing the clipped involved node that was localized before treatment. And we can see that targeted axillary dissection using a range of techniques reduces the false negative rate to acceptable levels and as low as 2% in some studies. So targeted axillary dissection following neoadjuvant systemic therapy in patients who've had a good treatment response has become the standard of care in the UK. And we know this approach is safe from this very large retrospective cohort study published last year, which included 1,144 patients from 25 centres in 11 countries, which looked at patients with stage 1 or stage 2 breast cancer who converted from clinically node positive to node negative following neoadjuvant systemic therapy. They included patients having sentinel node biopsy or targeted axillary dissection, and they looked at the impact of omission of axillary clearance on axillary and local regional recurrence. And as summarised in this table, the rates of axillary recurrence were exceptionally low, 1% or less at 3 and 5 years, and that there were only 4 axillary recurrences in the entire cohort, really highlighting this approach is safe. There was no difference in any of the recurrence parameters, irrespective of whether the patient had a TAD or a sentinel node. And what this is really speaking to is the fact there's no benefit to taking away disease that isn't there. But notably, 80% of these patients had nodal radiotherapy as part of their treatment. So what do you do with residual disease post-neoadjuvant treatment? Do we still then need to perform a clearance? Well, I think increasingly, we think that this is probably not necessary. And this is because we have increased understanding that it's not just surgery that we can use to treat the axilla, but radiotherapy has a really important role to play. And some of these data are extrapolated from patients having primary surgery. And this is the Early Breast Cancer Trialists Collaborative Meta-analysis looking at nodal radiotherapy. And what this showed is that irrespective of the type of cancer you had, there is a benefit to nodal radiotherapy. And it might be that we can apply the Amoros principle so that essentially radiotherapy is non-inferior to surgery in patients who have residual disease following chemotherapy. But can we actually directly apply these findings? Because we know that patients with advanced disease at presentation are at higher risk, and that patients with residual disease post-chemotherapy do worse and have higher rates of recurrence per se. But just because patients have chemo-resistant disease, this doesn't mean their disease is radio-resistant. And we know that radiotherapy is really good at eradicating small amounts of disease, not bulky nodes, but the bulky nodes could be removed at surgery. So there are 2 current trials looking at omission of axillary node clearance in patients with residual disease following chemotherapy. There's the Alliance A11202 trial led by Judy Berry at the Mayo Clinic, which is now completed. This is looking at patients with T1 to T2 N1 disease at presentation, converting to clinically node negative after neoadjuvant systemic treatment, having a TAD or a sentinel node, but then who have residual disease based on this. And then these patients are randomized either axillary surgery and nodal radiotherapy or axillary and nodal radiotherapy. And the primary endpoint is disease-free interval. This trial is completed and we are now eagerly awaiting results. The second trial is the Taxus trial I've already mentioned. This also has a neoadjuvant arm looking at patients with residual disease following neoadjuvant treatment. Patients are randomized 1-to-1 to targeted axillary surgery and radiotherapy or clearance. And this is looking at disease-free survival. So I think this is very much a case of watch this space. I think the future for axillary surgery is that less is more, and we will increasingly de-escalate surgery to improve outcomes for patients and minimize morbidity. But what we need to do is have high quality evidence on which to support these decisions, because we don't want to squander hard-won gains in oncological outcomes just because less is potentially a more attractive option. Thank you very much. I'm happy to take any questions.
Thank you for that excellent talk, Shelley. Also very, very thought-provoking for all of us. I'm wondering if we have some questions from the panelists, from our other speakers, or from the audience.
Again, I would like to ask a question. Thanks, Shelley. That was a very comprehensive presentation, highlighting how the practice has changed and shifted towards less surgery. Now, one scenario, again, that many practices find a bit challenging is what, for example, we do if, let's say, we have somebody with hormone receptor positive HER2 disease, we do sentinel lymph node biopsy, and we find 2 out of 2 nodes. Many practices do push for an axillary clearance, because then the argument is that if you find more nodes, they might be eligible for a CDK4/6 inhibitor. But I would be interested to know what your thoughts and the other panelists, what they think about this.
I think that's an excellent question, Marius, and it's definitely something that has come up in our MDT. But Yana de Boniface and her team have done a fabulous analysis of the CENIMAC data, and they've basically done a calculation about the number of axillary clearances that would need to be performed to identify one patient that would benefit from abemaciclib. And it's 108 axillary clearances would need to be performed to identify one patient who would get benefit from abemaciclib, but 13 patients would get life-changing lymphedema. So we are very much against it, and I think the data doesn't support it, and particularly as things are changing with the Natalie data, which give don't require the 4 nodes. I think things will change. So we're very much against it, and we very much use the 108 clearances data from the CENIMAC trial to support our decision making. And hopefully in the UK, the Natalie and ribociclib will be approved in the near future, so we won't be facing those decisions.
Again, I think it is very important, as you said, to highlight that the data does not support doing more extensive surgery in the axilla, only to inform potential use of a CDK4/6 inhibitor for a very slim benefit. So again, a take-home message is do not do unnecessary axillary dissection just in case you find more disease in the axilla, so that you can give a CDK4/6 inhibitor in some patients. Again, thank you very much, and that was a great talk. Thank you.
I see the hand of Michael.
Yeah, I would just advise a word of caution here. I'm not so much convinced by that theoretical calculation. It's of the CENIMAC trial. This is a flawed analysis, I'm sorry to say, because it compares eventually apples with oranges. I think Shelley has already indicated what the potential solution might be, and that is the targeted approach. So personally, I would expect that a more targeted, a more limited axillary diagnosis will substitute complete axillary clearance. I mean, just the word clearance already indicates that that's not a diagnostic procedure any longer. However, I think it's not only CDK4/6 inhibitors. We have in many countries, olaparib can only be given if you have proof of positive nodes, pembrolizumab. And these are agents that improve patients' outcomes by 5 to 10% absolute. So we don't want to easily give that away. Obviously not at the price of 100 unnecessary axillary dissections. But what I would, unfortunately I cannot provide evidence for that, but what I do is I usually, particularly after neoadjuvant, I will always try to be as targeted as possible, or remove 5 or 6 nodes, which is diagnostically perfect for the MTD discussion, but usually does not have the traditional morbidity of axillary dissection. So I think The general message is undisputable, but in very specific situations, particularly after initially positive lymph nodes, we need to move a little bit cautiously in order not to over de-escalate, so to speak. But I have not gone back to do a secondary axillary dissection for the last, I don't know, 3 to 4 years, just for diagnostic reasons. I think there is no indication for that. But at the same time, there's no indication to say, which nobody suggested here, it's not relevant any longer. We would all love not to be depending on number of lymph nodes for our indications for adjuvant treatment, but we need to provide step by step the evidence, and hopefully targeted axillary dissection will substitute for any high morbidity diagnostic procedure. Just my 2 cents. Sorry.
But I think this is a good segue for the last part of our discussion, which will be led by Professor Yizhou Jiang. I hope I pronounced that correctly. So he is a professor from the Fudan University Shanghai Cancer Center, and his focus is on cell biology, cancer research, and molecular biology. He has several notable publications, including in Nature and in Cell. And today he will deliver a talk that will probably be very insightful for all of us as surgeons about personalized surgery strategies based on molecular subtypes of breast cancer. Thank you, Professor Jiang, for being one of our panel speakers.
Okay, thank you very much. I will share my slides. Okay, hello everyone. I am Yizhou Jiang from Fudan University Shanghai Cancer Center. I am a breast surgeon, but today I will talk about something about the translational research of triple-negative breast cancer. The topic is the molecular subtyping and the precision treatment of triple-negative breast cancer. We all know that triple-negative breast cancer, TNBC, is characterized by the negative expression of estrogen receptor, progesterone receptor, and HER2. And patients diagnosed with TNBC have a high risk of early recurrence and metastasis. In addition, due to its lack of explicit targets, patients do not benefit from endocrine or the traditional HER2-targeted therapies. Although chemotherapy is the standard treatment for triple-negative breast cancer for a long time, its efficacy is far from ideal, and there remains much room for improvement. So in the past 10 years, our group has been focusing on TNBC. First, we tried to conduct the phase 3 clinical trials to modify the chemotherapy regimens for triple-negative breast cancer. For example, in the pattern trial, by adding the paclitaxel and carboplatin into the adjuvant chemotherapy regimen of triple-negative breast cancer, we can reduce 5-year recurrence risk by 31%. And in the CBCSG 010 trial, which is also a adjuvant phase 3 clinical trial, we can add capecitabine into the adjuvant chemotherapy and reduce the recurrence risk by 43%. And for the CBCSG 006 trial, which is a phase 3 clinical trial in the first-line treatment of triple-negative breast cancers, we proved that the gemcitabine plus cisplatin showed better progression-free survival versus the paclitaxel plus gemcitabine. However, we can see that the survival improvement led by chemotherapy is still limited. In recent years, the scientists have discovered that triple-negative breast cancers are not a unified population, but a group of highly heterogeneous disease composed of biologically distinct subtypes. So we tried to look into the molecular essence of triple-negative breast cancers, divide them into different subtypes, and then develop the subtype-based precision treatment for this highly heterogeneous disease. So in the recent 5 years, we did a lot of research in the molecular subtyping and precision treatment of triple-negative breast cancer by constructing a large multi-omic cohort of triple-negative breast cancers. We can divide TNBCs into 4 subtypes with subtype-specific targets and precision treatment. Furthermore, we went on to optimize the subtyping method, developing novel druggable targets for each subtype. And finally, we went into the clinical application of this subtyping method we call the Fudan subtyping. We developed the clinical feasible kits for the detection of Fudan subtyping and conduct a series of clinical trials to prove the efficacy and the safety of subtyping-guided precision treatment. So first, we took advantage of multi-omic technologies to work on unveiling the molecular features of triple-negative breast cancer. We analyzed multi-omics data from 465 Chinese triple-negative breast cancers, which was the largest single-center multi-omics cohort ever reported. And based on the clustering of transcriptomic data, we can divide the triple-negative breast cancers into 4 subtypes. The first one is a basal-like immunosuppressed. It is featured by a high level of genome instability and high frequency of germline BRCA1/2 mutations. It is sensitive to platinum-containing chemotherapy and PARP inhibitors. The second subtype is immunomodulatory subtype, the IM subtype. It is an immune hot tumor with an elevated expression of immune checkpoint like PD-1 and PD-L1 and may benefit from anti-PD-1 immunotherapy. The third one is the luminal androgen receptor subtype with a high expression of androgen receptor and a high frequency of HER2 activating mutations. Is sensitive to anti-HER2 targeted therapies such as the TDXD and CDK4 and 6 inhibitors. And the last one is a mesenchymal-like subtype. We call it MES subtype. It is featured by the activation of angiogenesis pathways, the cancer stem cell features, and is sensitive to anti-angiogenesis targeted therapies and STAT3 inhibitors. So we established a 4 subtype classification system based on the multi-omics data, and then we went on to modify the subtyping system and translate it into clinical use. So later we went on to develop the novel druggable targets for the luminal androgen receptor subtype and basal-like immunosuppressed subtype. These two subtypes are associated with poor survival, as they are all immune cold tumors and may not benefit from the traditional anti-PD-1 immunotherapy. So we went into look into the translational research to remodel the tumor microenvironment. For example, we targeted the metabolites or targeted the key cell subtypes in the tumor microenvironment to turn the cold tumors into hot tumors, and finally sensitize the immunotherapy. So for the basal-like immune suppressed subtype, we identify a critical metabolite called GDP-mannose. And mechanistically, GDP-mannose can cause the ubiquitination of BRCA2 and induce homologous recombination repair deficiency of triple-negative breast cancer cells. And further, it can cause the double-strand DNA damage and activate the cGAS sting pathway, and finally sensitize the immune checkpoint inhibitors. And for another subtype with poor prognosis, the luminal androgen receptor subtype, we also identified a key metabolite metabolic feature. The luminal androgen receptor subtype is hypersensitive to ferroptosis inducers such as GPX4 inhibitors. And in the preclinical models like the PDX or PDO, while adding the ferroptosis inducers, we can see the significant reduction in the cell viability in the luminal androgen receptor subtype compared to the other three subtypes. So we propose that targeting ferroptosis in combination with or without the immune checkpoint inhibitors might be a promising precision treatment method for luminal androgen receptor subtype. So finally, we went into the clinical translation of this Fudan subtyping method of triple-negative breast cancer. First, we invent a clinical feasible method using the immunohistochemical staining to identify the 4 subtypes of triple-negative breast cancers in our clinical settings. With the staining of FOXC1, CD8, AR, and DCLK1, we can divide the triple-negative breast cancer samples into 4 subtypes in our clinical setting in like 1 or 2 hours. Then we went on to develop a rapid, dynamic, and non-invasive molecular subtyping assessment based on the triple-negative breast cancer multi-omics cohort by collecting the radiomics images and the digital pathology data. We can work with the scientists to develop the artificial intelligence models to predict the molecular subtyping and the druggable targets of certain triple-negative breast cancer patients. For example, we can use the MRI images from the triple-negative breast cancer patients, and we can extract the key features, and using a machine learning method, we can build a model to quickly and precisely predict the subtypes, and this model was finally validated in external cohorts with a very high area under curve value. On the other hand, we can also use the HE staining slides to collect the digital pathology data, also build the artificial intelligence aided model, we can predict some important therapeutic targets for the triple-negative breast cancer patients. For example, the PIK3CA somatic mutations, which predicts the sensitivity of PI3K inhibitors. And we also built these models to precisely and for the fast prediction of these therapeutic targets. And then we went on to conduct a series of clinical trials for the precision treatment of triple-negative breast cancers. First, we built a multi-gene signature to predict the recurrence risk for triple-negative breast cancer patients after surgery. And then we conduct the first prospective clinical trial to validate the prognostic value of this multi-gene model. We call it BCTOP-TA01 trial. We can see that this model can precisely predict the recurrence risk for triple-negative breast cancer patients. And for the patients with high risk, while we use a extended adjuvant chemotherapy, we use by adding gemcitabine and cisplatin into the TAC therapy, we can get a significant 3-year DFS improvement in the high-risk patients. For the extensive chemotherapy group, we can achieve the 3-year DFS rate of 90.9%, while in the traditional EC followed by T group, we can only get the 3-year DFS rate of 80.6%. Then, based on our theory, we conducted a future trial in the heavily pretreated metastatic triple-negative breast cancer patients. First, by using the immunohistochemical staining subtyping method, we can divide these triple-negative breast cancers into 4 different subtypes. Then we use next-generation sequencing to identify druggable targets. Finally, we can divide these patients into different treatment arms. And for these locally advanced or metastatic triple-negative breast cancer patients, they are the average of previous treatment is 3 lines, and we divide them into different subgroups and giving them the subtype-based precision treatment. We can get an ORR in the ITT population of 29.8%, superior to previous report by chemotherapy. It's only 5 to 10%. And especially in the immunotherapy arm, we got an objective response rate of 43.5%. Then we went on to adopting the subtyping method in the first-line treatment setting of triple-negative breast cancer. We conducted a randomized controlled umbrella clinical trial. We call it the Future Super trial. For the first-line treatment of triple-negative breast cancers, we divide them into 4 different subtypes. Using next-generation sequencing, we identify the targets of these tumors, and then we divide them into 5 different treatment arms. In each arm, we did a randomization. The blue one will receive subtype-based precision treatment, and the red one will receive chemotherapy as a control arm. Finally, we will compare the survival, the safety, the response rate of all of these precision treatment arms and all of these chemotherapy arms. We can observe a significant improvement in the primary endpoint, the median progression-free survival. The subtyping-based precision treatment arms, we got a median PFS of 11.3 months, while in the chemotherapy arm, we got a median PFS of 5.8 months. So by adopting the subtyping-based precision treatment, we can reduce the disease progression risk by 62%. So this is a paper published in Lancet Oncology last year. So nowadays, we have conducted a series of clinical trials on the precision treatment of triple-negative breast cancers. The future trial is the initial exploration in the heavily pretreated metastatic triple-negative breast cancer patients, and the future C+ trial for the first-line treatment of immunomodulatory triple-negative breast cancers. The future super trial is the first-line treatment of different subtypes, and now we have future super 2.0, future 2.0, and other clinical trials to further confirm the safety and efficacy of precision treatment based on the subtyping method. And now we also ask how to conduct the subtype-based precision treatment for other types of breast cancer, especially for the hormone receptor positive and HER2 negative breast cancers, or we call the luminal breast cancers, because luminal breast cancers are of high heterogeneity, and the patients with luminal breast cancer may face with a late recurrence risk. So we first constructed a large and comprehensive Asian multi-omics cohort of different subtypes of breast cancers. We call this the Chinese Breast Cancer Genome Atlas, the CBCGA, compared to the TCGA, the Cancer Genome Atlas, by integrating the genomics, transcriptomics, proteomics, metabolomics, radiomics, and the digital pathology data. We have a large multi-omics cohort constructing of 773 cases of breast cancers, which will allow us to identify novel clinical clues using multi-omic data. And we propose the multi-omics cohort, and we develop the molecular subtyping of luminal breast cancers based on the molecular multi-omics data. We can divide the luminal breast cancers into 4 different subtypes. The first one we call the canonical luminal breast cancer, which is highly sensitive to endocrine therapy, is associated with favorable prognosis. The second one is the immunogenic subtype. It is an immune hot subtype of luminal breast cancer, and in the I-SPY 2 clinical trial, while divided into the immunogenic subtype, these tumors will have a pathological complete remission rate of nearly 85% by using the immunotherapy, neoadjuvant chemotherapy. And the third one is a proliferation subtype of luminal breast cancer. It has a high Ki-67 index, activated cell cycle, and is associated with a high genome instability, maybe benefit from CDK4 and 6 inhibitors and PARP inhibitors. And the last one is the receptor kinase driven subtype. It is resistant to endocrine therapy and may benefit from tyrosine kinase inhibitors such as sorafenib and apatinib. So we formed a subtype-based precision treatment for hormone receptor positive and HER2 negative breast cancers. Learn from the experience of triple negative breast cancer, we built a clinical trial platform to facilitate clinical translation of this theory. First, we developed the artificial intelligence-based subtyping using the whole slide images of these tumors, and we can do the subtype in 1 hour. Then for the patients in the neoadjuvant setting, or the first line or second line settings, we all conducted the subtype-based clinical trials to prove the efficacy of subtyping-based molecular precision treatment for luminal breast cancer patients. So to summarize my talk today, triple-negative breast cancers are groups of highly heterogeneous breast cancers, and uncovering the genomic and transcriptomic landscape of triple-negative breast cancers has enabled us to give subtype-based precision treatment. And we are working on increasing the dimensions of omics for target identification, and we conduct a series of clinical trials to prove the efficacy led by the molecular subtyping and precision treatment. And finally, we proved that subtype-based precision treatment can partially enhance the treatment efficacy in triple-negative breast cancer patients, and may be applied for other subtypes of breast cancers like the luminal breast cancers. So thank you very much, and I'm happy to take any questions. Thank you.
Thank you, Professor Jiang. I think your talk really shows how fascinating, endlessly fascinating breast cancer is. And as we are developing so many tools to understand its biology, then it becomes even more fascinating, even for surgeons. The molecular profile of breast cancer is really very, very interesting for surgeons. Maybe I would like to ask for the first part of your talk related to the subtyping of TNBC patients. Would you comment on how this tool can be used to, in a way, tailor the duration of treatments for example, immune therapy for patients undergoing treatment for TNBC? Have you explored the question of using your molecular profiling tool to probably shorten the duration of immune therapy for the TNBC patients?
Yeah, okay, this is a very good question. Thank you. And actually, we are conducting clinical trials in the neoadjuvant settings for different subtypes of triple-negative breast cancers by using the subtype-based precision treatment. We can compare the PCR rates of different subtypes, and for those patients have a better response to certain regimens of chemotherapy, we can improve the rates of breast conserving surgeries. And now we observe that a very favorable response of the immunomodulatory subtype to the anti-PD-1 immunotherapies, and we can observe improved rates of breast conserving surgery in that subtype of breast cancer. Yeah.
Thank you very much. May I know if our other expert panelists have questions? maybe one last question for Professor Jiang. For the second part of your presentation for the luminal subtypes, did you observe differences for those who have switched subtypes, and how this impacts the surgical approach or the surgical outcomes of these patients?
Yes, we conducted some analysis of this phenomenon called the switch of subtypes before and after a new adjuvant treatment, or in the primary and the paired metastatic settings, and we can see like the 10% of these cases will have a switch of subtypes. For example, from the canonical subtype to the RTK-driven subtype, and now we haven't planned to conduct the clinical trials, especially for the personalized surgical treatment. Yeah, hopefully in the future we can do something in the guidance of personalized surgical using the subtyping method. Thank you.
Thank you for that. I guess we can ask our speakers. Michael, yes.
Yeah, just a brief comment. Congratulations, Yizhou, to this research. I mean, these were super excellent, highest level publications, and I think it underlines, and that's, for me personally, mission statement. This needs to be done also by surgeons. So this is a message to our young colleagues: don't hide in the operating theater. At least some of us will have to go to the lab, learn these techniques, understand translational, even basic research to some extent, and then do clinical trials, as our colleagues at Fudan show in a role model way. So congratulations for this. But this should be done everywhere. If surgery is confining ourselves to the theater, then we are going to eventually disappear as a scientific discipline. And I think what Yizhou has shown shows that the contrary is true. Actually, we can lead the way in multidisciplinary research, and we should do so. And I think that's an important statement, at least for me personally. So sorry, Carmela, but I tried to use the opportunity.
No, I think that's exactly the reason why we, CSO and JMed and ESSO, are doing these collaborative talks focused on molecular insights, specifically to encourage our young surgeons to look into this and to expand their perspective beyond the operating room. As you said, this is really the reason why we are doing this together. And hopefully this will help us improve the outcomes for our patients by really understanding the biology of the disease, apart from the surgical techniques that have been continuously improving over the years, as what our expert panels have today discussed. But maybe, may I know if there are last key messages from our speakers? So I guess if not, the webinar today will be uploaded in the ESSO website, so it will be free for everyone. There will be another series of webinars on different cancer diseases, colorectal cancer and hepatobiliary, on the same topic as well. And we are all looking forward to meeting you all again in multiple webinars by CSO and ESSO. Thank you so much to everyone. Thank you to my co-moderator, Marius. Thank you to all our expert panels, speakers for today, and hope to see you soon again. Thank you all. Have a good day, everyone.
Thank you very much.
Thank you. Thank you very much for all of
Thank you.
Bye-bye.
Bye.
participation.
Bye-bye.
Yeah.